Hello and welcome back to Advanced Human Gross Anatomy. This is our 10th dissection. We're going to be finishing up the female reproductive system today. This is the last lecture for the coursework that we've talked about on the thorax, the abdomen, and the pelvic portions of this course. So we've gone through a lot of material and we're going to finish it up with this. This is a bit of a shorter lecture that will give you time to spend time in the other areas if you want to be reviewing before we move on to the next units. So let's start in with the ovaries. You can see this is a cross section, a transverse section view, looking into the pelvis from the top down, and you can see that Netter has drawn these ovaries right here and right here. Here's the right ovary, here's the left ovary. These are actually quite generously drawn. They're quite large. They're quite a bit smaller in size than the testes themselves, and certainly smaller in postmenopausal women too. So our donors are likely going to be much smaller than this size. They attach to the uterus. Here you can see where they attach on the right side and the left side through the ovarian ligaments. The broad ligament, which you can see here, again, is just part of the peritoneum from the abdomen that comes down and drapes over the uterus. It drapes over the bladder. Here you can see part of it here, over the rectum as well. This broad ligament helps hold the ovaries into place. Where it attaches kind of to the ovary, where it crosses over the ovary, we call that the mesovarium. So you should be able to see part of that broad ligament coming over there, the mesovarium. And then you also have this mesoalpinx. Alpinx is Latin for tube, and that's where that broad ligament is going to help hold the fallopian tubes on each side to the body wall as well. So very stable in there through the mesovarium and the mesoalpinx. The round ligaments you've seen here on the previous dissection, the round ligaments coming laterally. This is going to be help attach the uterus to the body wall laterally and anteriorly. Comes off of the lateral anterior aspect of the uterus on each side and goes to the deep inguinal ligament. From the gubernaculum, remember when we talked about how the gubernaculum pulls the ovaries and the testes down early in development, and that leaves the ovaries in the pelvis. Obviously, for the male, we talked about it bringing the testicles down through the inguinal canal into the scrotum. But that's not what happens here. The round ligament then will bring the gubernaculum rather will bring the ovaries down into the pelvic cavity, and then that will then just attach itself into this deep inguinal ligament. It actually does technically go into and through the inguinal canal down to the level of the labia majora, which isn't an easy dissection to find. You could probably just take my word for that, but feel free if you want to go search for that, you certainly can, but I think it's kind of difficult to identify and find. The ovarian ligaments we've talked about here on the outside, these hold the ovaries to the uterus medially on the outside here. The ovarian ligament, I'm sorry, that's the suspensory ligament. The ovarian ligaments help hold the ovary to the uterus wall here. And then the suspensory ligaments that we've talked about in the past, these help hold the ovary to the body wall laterally. So they have a medial attachment toward the uterus and then a lateral attachment to the body wall. And again, that suspensory ligament is just part of that peritoneum as it gets pulled down from the gubernaculum down into the pelvic cavity. That's the connective tissue containing the nerves, vessels, and lymphatics that will get pulled down with it. Let's move on to the circulation in the pelvic cavity. We spent some time in the last lecture looking at the male, at the branches off the internal iliac artery in the male. We'll do the same thing for the female. It's pretty much the same. There are some differences that we'll see as well, but pretty much the same thing. So if we look back up here, here's the aorta as it would come down and then split into the common iliacs on the right and the left common iliac. And those are going to follow along the pelvis near the pelvic brim, and then they'll split. So here you can see the right common iliac is cut off. The left common iliac is here. That will split into the left external iliac, and the right, the left common iliac turns into the left external iliac and the left internal iliac arteries. So if we look at this internal iliac here, that's where we'll focus most of our time. The external iliac goes under that inguinal ring and then becomes the femoral artery into the thigh. So if we look here, you can see a good shot of this internal iliac, and there's a posterior branch, and there's also an anterior branch here. So if we look at the posterior division first, the first thing you'll find is this median sacral artery that travels, it kind of ascends up the front of the sacrum toward the lumbar spine. You can see that here. The next branch off you'll see is the superior gluteal artery. This exits with the sciatic nerve and supplies the structures above the piriformis. So the gluteus medius, the gluteus minimus are supplied by that superior gluteal artery here. And then the lateral sacral artery, you can see coming down this way. This is going to go along the lateral sacrum where the ventral rami are gathering in the sacral plexus. So you can see where that's coming down here. So all of those off the posterior division. Off the anterior division, maybe easier to see on this one, the anterior division of the internal iliac. What you're going to see, first one, again, typically, almost always, the first one is going to be the umbilical artery. That comes off, and it goes to the anterior abdominal wall. It will also send a branch called the superior vesicle, which is going to supply nutrition to the top of the bladder. Just like in the male, it did that. And then it will continue, you can see it here, continuing on to become the medial umbilical ligament, which is going to go on the inside of the abdominal cavity up toward the umbilicus, just like in the male as well. The second branch off here, Netter has shown it kind of twisted here. They kind of crisscross each other, but the obturator artery comes off that internal iliac as well. And it's going to go, you'll recognize this because it follows right through the obturator foramen. It's going to, along with the obturator nerve and vein, it will go down into the inner medial portion of the thigh and supply those areas with nutrition. Now, the next ones off here are going to be a little bit different. In the male, this was the inferior vesical artery, which would go to the bladder, the bottom of the bladder, and the prostate. But in the female, there's no prostate, so you're going to have a uterine artery and a vaginal artery coming down towards those. Towards the uterus and the vagina, respectively. So again, branches off of that internal iliac artery. The next one off here you'll see is the middle rectal artery. You can see the middle rectal here coming down to supply, going back to the rectum. Now, if you'll remember, there are three arteries that supply the rectum. Off of the inferior mesenteric, we learned way back that was the superior rectal supplying that. From the anterior division of the internal iliac here, you can see the middle rectal going back to the rectum. And then the internal rectal was a branch off the internal pudendal, which you can see. I'm sorry, the internal pudendal. So the inferior rectal off the internal pudendal, and then the middle from the internal iliac here, and then the superior rectal from the inferior mesenteric artery. So the venous drainage from the rectum gets a bit tricky. The inferior rectal off of this internal pudendal will go more toward the caval system for venous drainage, whereas the superior rectal will go back into the liver through the portal system. So a couple different ways to drain the rectum there, but that's where that can be. And then the next one off would be that internal pudendal artery, which we've seen before, coming down here, giving branches to the inferior gluteal artery. Is going to be just below that, the inferior gluteal coming down here, which is going to supply gluteus maximus. So we've talked about the internal pudendal quite a bit, going into the bottom of the perineum, and then the inferior gluteal artery here going to the gluteus maximus. Okay, the obturator nerve, which you'll see as well, that's actually quite a substantial nerve. Coming down through the obturator foramen, and that will give rise to the it will come down into the medial aspect of the thigh for the adductors of the thigh. Here you can see Netter has drawn in this muscle right here, this obturator internus muscle, which covers the inside of the obturator foramen. The obturator artery and nerve are going to go through this. They're going to puncture through that on their way through the obturator foramen. On the outside of that obturator foramen, you're going to also find the obturator externus muscle, which is not shown here, but that's on the outside. And again, the obturator nerve and artery are also going to penetrate through that as well on their way down to the medial aspect of the thigh on each side. It's worth reviewing the pelvic diaphragm. Again here, the musculature, I've referenced this like a sling going down into the pelvic cavity, the bottom of the pelvic cavity. Again, the coccyx, I would argue, is not a vestigial organ. It is not optional. I think it's a big deal if that gets taken out. Just structurally, of all the things that attach to it here, really seems to be very important in holding the pelvic organs in place in upright animals like us, like the humans. Here you can see in the middle of the openings, the urethral orifice, the opening to the vagina and the rectum. And then remember the levator ani, which is the puborectalis, that this musculature that comes down doesn't actually attach to the coccyx, kind of slings around the rectum on each side. The pubococcygeus muscle coming down to the coccyx, and the iliococcygeus on each side coming down to attach to the coccyx as well. That's the levator ani. And then the rest of the pelvic diaphragm is composed of the ischiococcygis, or sometimes in textbooks just referred to as the coccygeus muscle. So that's the pelvic diaphragm. Kegel exercises, maybe you're familiar with those. These are going to just contract this musculature and give tone to those muscles, and in the delivery process will help to prevent any tearing or damage during the delivery process of a baby. Let's see, if we look now at the vestibule, remember that the vestibule is this area inside of the labia minora right here. It contains the openings to the vagina and the urethra. At the anterior aspect of the vestibule is the clitoris, which is under the prepuce here, which is just the skin of the labia minora that comes on each side and covers the clitoris. So you can see the glands of the clitoris, the body of it here. The crura, which Netter has drawn here as well, where that skin will come up, that will come up and kind of fold back like this. This erectile tissue coming on each side and folding backwards, kind of looks like that cross, the crura. We saw something similar in the male as well, coming together at the glands of the clitoris here. So you can see that erectile tissue, and the external urethral orifice where the urethra is exiting, and the vaginal orifice here coming together where within the vestibule, again, that external vaginal orifice. This is important just to get that anatomy correct, in case one day you decide that, in case one day you're asked to catheter somebody. I've heard of instances where people will catheter the wrong opening, where the catheter will go up into the vaginal opening instead of the urethra to get to the bladder, which, besides just being kind of awkward, it's not very helpful to catheter the vagina. So you might want to just be aware of where you're putting that. The periurethral glands are on the outside. They're within the vestibule, but kind of around the urethra, also called Skene's glands. They're on either side of the urethra. They have a basal level of secretion at all times, but they will significantly increase their secretions with sexual arousal. The perivaginal glands, or Bartholin's glands, or another name for those are these greater vestibular glands around the opening to the vagina, also important for initial penetration during intercourse. So just keeping the vestibule lubricated. The urogenital diaphragm we've talked quite a bit about here, the area between the two inferior rami of the pubic bones here. We've talked about the superficial, that it's superficial to the pelvic diaphragm, which would be deep to this, which is basically, the urogenital diaphragm is basically just two layers of fascia with a couple things inside of there. The deep transverse perineal muscles. Here you can see that the superficial ones have been dissected off. You can see the deep transverse perineal muscles. Also the sphincter urethrae, which is, or the external urethral sphincter within that urogenital diaphragm as well. Let's talk now about some arteries here. This should be review, but off of the abdominal aorta, you're going to have the gonadal arteries coming down in the female to the ovaries and the male to the testes coming down here. And then the venous drainage, remember, is different on each side. So on the right side, the gonadal veins, the ovarian vein or the testicular vein, is going to just go right back into the vena cava. But on the left side, it's actually going to go up into the left renal vein and then enter the inferior vena cava here. So right, it goes right into the vena cava. Left is going to go to the renal vein and then back into the vena cava. Here you can see the ureters coming down, crossing over, kind of near that bifurcation of the common iliac going into the internal and external iliac. So this is what we spent some time trying to dissect out or identify some of those branches off the internal iliac artery. Okay, the bladder, let's take a different look at the bladder. Again, the bladder immediately behind the pubic symphysis. So when you're looking at the pubic symphysis, directly behind it in males and females, every time it's going to be the bladder. Should be fairly easy to find. Here again, pubic symphysis directly behind it. It does have smooth muscle within the wall of the bladder. Collectively, that smooth muscle is called the detrusor muscle, which contracts to expel urine from the bladder. So you can see that here. If we look now at the uterus, so right behind the bladder and the urethra would be the vagina coming up. Here you can see the fornix of the vagina, the top portion here, and then the cervix, which is this first portion of the uterus. So the cervix is this narrowed bottom portion near, kind of superior to the vagina, and at the end of the kind of the base of the uterus. It's prone to cancer in females. Again, it has that same histological kind of development. In development, it's the same histology as the prostate in the male. So both of these are kind of prone for cancer within in the female, the cervical cancer here. So the cervical canal would be this opening between the top of the vagina or the fornix into the body of the uterus here. The cervical canal always contains a mucus plug, which allows there to be it doesn't allow air rather to come into the uterus, so it keeps that closed. It's like a block, a plug that will hold that. Now, something miraculous happens that changes the biochemistry of this area during ovulation, and that plug will allow sperm to pass through through the cervix into the uterus to get to the fallopian tubes where the fertilization typically takes place. So that's what happens at ovulation. But that mucus plug is there all the time. The body of the uterus being right here, just the main portion of the body. The broad ligament, again, coming down, part of that abdominal peritoneum that comes down and envelops the uterus and the bladder and the rectum. comes over that area. The uterine cavity, just the cavity within the uterus, inside the body of the uterus, which is this space, the little slit that you can see here. It's more like an envelope, though. It's not like a cavity. It has a front and a back to it, but not really any sides to it. So that's what's unique about the uterus here. It's usually this is where the site of implantation of that fertilized egg will take place, either on the anterior or posterior aspect of the body of the uterus. The fundus of the uterus is this rounded portion up on top of the uterus, and then the uterine tubes, or the fallopian tubes, coming off of the fundus, one on each side, are arching around the ovary, one on each side here. A different view of that is here. Here would be the fornix of the vagina, superior vagina. Here's the cervix, the cervical canal, and then the uterine cavity within the body of the uterus. You can see the fundus of the uterus right here. And then the fallopian tubes. Now, if we talk about the fallopian tubes, they widen at the ends to catch the ovum that gets released from the ovary upon ovulation. And that portion at the end is called the infundibulum, which literally means a funnel. So you can kind of see how it's a little wider here. Now, it's much wider in this drawing than it actually is. There are extensions within the wall of the tube that fold into the lumen of it. So at any point, the inside diameter is approximately the diameter of 2 human hairs. It's really quite small. So again, Netter has drawn this very generously just to kind of show some of the nuance of it, but that's where that is. Now, again, one of the miracles of life, just the miracle of life, really, I think, is when the ovary when the ovum matures and gets released from the ovary itself. It gets released just into the pelvic cavity, and miraculously finds its way into that infundibulum of the fallopian tube. Now, at the ends of the fallopian tube here, you can see these fimbriae. They call them these finger-like folds at the edges, and at the end of the infundibulum, these are typically soft, but will engorge with blood at ovulation and become more firm. And so they will also stroke. There's kind of a stroking pattern that happens at the edge of the ovary in an attempt to capture that released ovum. So that's probably one of the advantages that this area has, that it will kind of, it's not on it, but next to it, and will kind of help coax that released egg into the infundibulum of the fallopian tube. The ampulla is this main portion of the tube itself. It's the portion where fertilization will typically occur is within the ampulla here. An ovum will be released out of the ovary and enter into the ampulla, and it will be here for the first about 24 hours after ovulation. So it stays right within this fallopian tube, and that's typically where that sperm will be able to make its way into the ampulla to fertilize that egg. Now, ectopic pregnancies, I believe the term ectopic means to have the fertilized egg implant anywhere but the wall of the uterus, but it typically will happen into this ampulla portion here. If they're going to have an ectopic pregnancy, it is possible to have that fertilized egg implant in the wall of the fallopian tube within the ampulla. However, this is tragic because it's not possible for that fertilized egg to develop and grow properly, so it won't be a viable pregnancy. And if it's left there to grow, because that's what it does, it may be very unsafe for the female, with a potential rupture of the tube and internal hemorrhage and potential death of the mother as well. So very dangerous if that fertilized egg implants anywhere but the wall of the uterus, on either the front or the back cavity there. Okay. Let's see. What else should we talk about here? Let's talk about the uterine wall some more. So here you can see the parametrium, which is just this outer layer of the uterus that's continuous with the broad ligament. So the parametrium on the outside, the myometrium, which is the bulk of it, the majority of the uterine wall, is where the smooth muscle, which is important during labor and delivery. It will stretch tremendously during pregnancy and then contract upon delivery. That positive feedback loop kicks in and really starts to contract until homeostasis occurs by getting rid of the baby from the uterus. The endometrium, which is this inner portion here, the wall of the inside wall of the uterus. And this will actually change with each active menstrual cycle. So if we take a look at some blood supply here, you'll be able to see the uterine arteries coming in. Remember that branch off the internal iliac. The uterine artery will branch into these arcuate arteries, which then go into and ultimately become these, they kind of surround, this arcuate arteries surround the uterus itself, the wall of the uterus. They will then branch into these straight and coiled or spiral arteries that go into that endometrium. So here you can see the myometrium, the musculature, and then here would be that endometrium right here. And so they will then penetrate through that basilar layer, that base layer of endometrium, into this functional layer of endometrium. So over the course of the menstrual cycle, the endometrium increases in thickness and in vasculature. So this really gets engorged with blood in preparation to receive a fertilized egg for implantation. So at implantation, if that fertilized egg is going to come into and implant itself into the wall of the uterus, into this functional layer, the fertilized egg gets kind of almost enveloped within the wall of the uterus itself, which gives it its nutrition for development. As that egg matures, so does the vasculature, and eventually that vasculature becomes the blood supply that will flow for the placenta, which will be its nutrition. So the vessels of the fetus never mix with the blood from the mother, but the membranes do allow passage of nutrients and waste across that placental wall. So there is this basilar layer. You can see it almost kind of shadowed here. From the myometrium into the endometrium. You can see this portion here, this basilar layer, which is constant. That stays the whole time. And then there's a functional layer up top here that gets sloughed off if there's no fertilized egg that implanted into the wall of the uterus. This functional layer will get sloughed off at each menstrual cycle. Another shot of this is here. You can see the muscle, the myometrium here, and then here's this layer kind of arching up here, this basilar layer, stratum basale here, and then the functional layer, stratum functionalis, which is this portion, and then the inside of this would be where the lumen of the uterus, where that fertilized egg would sit. But this is what, if the uterus does not receive a fertilized egg, we don't need this functional layer anymore. Its job was to prepare for implantation of the fertilized egg, and if that doesn't happen, you slough this layer off in the menstrual cycle, and the basilar layer will create a new functional layer for the next month's potential implantation. Let's just talk quickly again about the rectum. Finishing up here, you can see immediately here's the urethral opening, the vaginal opening, and then immediately behind the vagina and the uterus is the rectum. Here, the anal canal coming down with the external anal sphincter and the levator ani, which again help to prevent bowel from releasing until more appropriately timed. There's that. And then let's finish here just by talking about a little bit of the lymphatic drainage from these areas. So very similar to the male, you're going to have superficial inguinal nodes, which are right on the inside of the inguinal canal here. They're draining the superficial genital region here and here. And then pre-aortic and then lateral aortic nodes on each side of the aorta draining the pelvic viscera, so the uterus, the upper portion of the vagina, the pelvic organs, the ovaries here. So this is what allows these inside the internal structures to easily metastasize, if there's cancer cells in there, to easily metastasize and go up into the abdomen, as if it gets into the lymphatic system here. Well, that's a lot of information. I hope you've learned a lot about the thorax, the abdomen, and the pelvis, and all of the structures that we've looked into detail about. That'll be the end of this first unit. From here, we're going to move on to the back and extremities, so we'll be looking forward to that. Hopefully this has been helpful, and I will look forward to seeing you in lab. Thanks.